Services at Inner City Underwriting Agency. And Clarita, I have a question for you.
Sure.
We're insuring all these people. A lot of them have never had to pay premiums. This is a lot of fiduciary responsibilities come with being insured. How are we going to handle that, especially coming from an agent broker point of view? How is it going to be done in the ACH? Are these people going to be, the new enrollees going to be required to write personal checks? And what kind of outreach are we doing to help them? This is a whole new, way of life.
So the question was, in terms of with the newly insured, there is a fiduciary responsibility. It's a new role, right? So they have insurance, they have to pay premiums. How do we make sure that happens, and how do we make sure that individuals understand that role, right? So I think that they come to a bigger picture of it's not just, so in terms of healthcare access, it's not just once you get the insurance, it's done. It's really about educating around health literacy, right? So I think who's going to be responsible for that? I think I don't have an answer to that. I know for us, in terms of be covered, we're looking at it as a long-term, right? Long-term education. Right now, it's educating individuals about the Affordable Care Act. What we'd like to do is how do we transition that to talk about health literacy, right? So how does the healthcare system work? I think what's going to happen and what we're seeing now, some of the organizations that we support through our community investments are already thinking about that, right? So how do you educate the community about health literacy? I think what's going to be happening is it's going to be included in probably the social service case manager model, right? So a lot of social workers currently play that role in connecting. I don't know, Charles, if you have a perspective about that in terms of in-person counselors or other educators in the community, but maybe you may have a broader view of that.
Sure. If the state and the federal government have taken this broad look at education, health education is very, very important, and that's much of what we do, but the financial education as well, the consumer education. So in the training for our in-person assister program, the notion of that consumer education and continuing consumer education, it doesn't stop once the enrollment is completed. The organization will continue to do periodic follow-ups with them. And there are several other consumer aspects of this that we have been very cognizant of. The payment types. We are very sensitive to the unbanked and underbanked. And so the notion, there was guidance that came down from the federal government probably 3-4 weeks ago regarding acceptance of the prepaid debit cards, etc. Some states are going with a branded instrument. Illinois is not exploring that right now, but we want to make sure that consumers are educated continuously and that they have the initial resources to take care of the financial responsibilities and understand what those financial responsibilities are.
I think we have a question here.
Well, thank you guys for sharing information. My name is Anthony Leslie. I'm with the Chicago Department of Family and Support Services. Now, my question is, how will the Affordable Care Act impact HMOs and PPOs, and also will dental coverage be covered under the Affordable Care Act?
Somebody else wants to weigh in there. Regarding PPOs and HMOs, there's no direct impact on that, but the market, aside from the implementation of the Affordable Care Act, I believe that the healthcare insurance market and the healthcare industry is moving away from the HMO model. That's an observation. I'm not a healthcare economist. But in general, it seems to be moving towards much more towards the PPO or the ACO kind of health home, medical home. In terms of the second part of your question was dental. Of the 10 essential benefits, pediatric dental is included in each plan, each private plan in the marketplace. It is also in the expanded Medicaid. However, adult dental, there will be adult dental health plans, standalone health plans. We're trying to clarify, and perhaps Roland can weigh in on this. I have a question that is pending response from the federal government now about whether one could go into the marketplace that was not purchasing one of the health plans and just purchase the dental. And if so, would they be eligible for the subsidies? And I don't know if right. And so our policy team is drilling down and collaborating with the federal government to answer that question.
What about vision?
Vision is, again, it is one of the 10 essential benefits for pediatrics. But the reality is that many of the health plans may very well cover those, and so it would be wise to have the consumers really take a look at what their needs are individually, their family needs, and really take a look and compare the plans.
And the age range for pediatric is?
Up to 18.
Up to 18? We'll take this question, and then we'll go right over here.
Yeah, my name is Mirta Gini. I'm with HRDI. One of the concerns.
What is HRDI? Sorry.
Yes, HRDI.
What is the HRDI?
Yeah.
Human Resources Development Institute.
Thank you.
I have two questions. One of them has to do with the large companies, or I don't even know how to place the question, but I have heard that the large companies, some large companies like Home Depot are already taking steps in lowering the amount of time for their employees and making them part-time because they can't afford paying for their insurance. And the second question has to do with how do the small businesses will be able to pay their employees for their.
Sure, and I'm sure that there's going to be a variety of opinions on this. There have been employers that have made what we feel by and large have been business decisions, irrespective of the Affordable Care Act. The notion of managing the labor cost and the associated health benefit cost is something that I think all businesses are very, very self-aware about. The notion of reducing hours to avoid having to cover based on the Affordable Care Act. First of all, what is referred to as the employer mandate has been delayed for a year. So I think that some aspects of that, at least in terms of its immediacy, I think that's off the table. There have been a lot of studies, the Kaiser Family Foundation, the Department of Labor, left-leaning, right-leaning think tanks, center think tanks have all studied this issue to see if there are any patterns since the implementation of since the signing of the Affordable Care Act into law, whether there's been any pattern of migration to more part-time. The Department of Labor came out with a report late last week that indicated quite the contrary, that of the jobs that have come back since the recovery, the majority of them have been full-time positions. So there does not appear to be any negligible impact. Certainly some business owners are making business decisions that may impact on that. There have been some other news stories about decisions that business owners have made, dropping spousal coverage. The dropping the spousal coverage does not necessarily mean that those spouses are not going to be covered through insurance. What some of those companies have done is they've said, if you have coverage through your employer, we'd like that to be the prime insurance that covers you. They're not just dropping the spouses off of coverage. They're saying, if you have a job or you have coverage through some other source, we'd like you to tap into that rather than our health insurance coverage. Anecdotally, there are some things that have occurred, but if you really drill down and look at the numbers, there's no pattern of migration to lower hours, and there's no big emergence of large employers that are booting their employees off of the employer-based healthcare. In terms of the small businesses, small for our purposes are 50 full-time employees or less. Just as it was mentioned earlier, we have the SHOP, the Small Business Health Options Program, which is a special part of the marketplace that will allow an employer to select for the coverage year of 2014, they can select one plan that their employees will go into, and they need to determine how much, if any, they're going to contribute. The employer would make that determination, and they'll say 50% or 60% of the premium cost. After they are registered, the employer's registered, they will receive a link. The link will be provided to their employees, and the employees just log in and sign up for their health care. It's noteworthy that 70% for this upcoming enrollment year, 70% is the enrollment, the participation rate. That means that 70% of a given small business's employees would need to actually enroll in the healthcare in order for that healthcare plan to actually actually roll out. They need to have 70% participation, except for the period of November 15th to December 15th of 2013. This November 15th to December 15th, there is no participation rate in SHOP. So if there was a small business owner, 50 full-time employees or less, that wanted to get involved and see how that's going to work out for their business, and they weren't confident that they'd have a 70% participation rate, that would be the time that they should really look at, November 15th to December 15th.
And that shop also is available for not-for-profits and also congregations, so something to keep in mind. They don't get the same percentage, it's less, but at least there is some tax credits also for the not-for-profits and for the congregations.
And I just want to just reiterate something that Charles had said in terms of, we, as I said at the beginning of my presentation earlier, so we've always been a nation of underinsured and uninsured individuals. And so while business decisions have been going on, for eternity, which has obviously had a negative impact on people's health insurance, and while we have the employer mandate, which has been delayed for a year, remember the individual mandate still stands. I believe we talked about that. And so we recognize that, and so if these individuals are finding they don't have health insurance because they're going to be part-time, remember that the marketplace is there for them. They may not be going through the shop right now, but they do have the marketplace to go through. And I think that's what we want to stress, that from October 1st, beginning October 1st, they can enroll into the individual marketplace. So let's just be mindful of that.
We have about 15 more minutes, so we're going to try to speed it along. We have a question here.
Thank you for your presentations. My name is Elvira Stevens, University of Chicago. I just want you to help us understand the difference between Be Covered and county care and other people on county care, like transition to Be Covered. How does that work?
So the question is the difference between county care and Get Covered in Illinois.
I'm sorry. Okay. Be Covered is a consortium group that is supported in great part, or is wholly, by Blue Cross Blue Shield of Illinois. Perhaps what you're speaking about is Get Covered Illinois, which is the official marketplace for Illinois. That is the portal in which people in Illinois will enroll for either the private health insurance in the marketplace or the expanded Medicaid. County care is a early release version, if you will, of the expanded Medicaid pool. Again, through the leadership of President Toni Preckwinkle, the Cook County Board President, and her health policy team, they applied for and were granted a waiver from the federal government to essentially roll out the expanded Medicaid pool early. I believe, did it open in April? In April. So they got an early shot at providing that expanded Medicaid for hundreds of thousands of Cook County residents But all it is an early release demonstrator program of the expanded Medicaid. That waiver is going to expire on December 31st, and all people that are enrolled in the traditional Medicaid or the expanded Medicaid through county care will be converted to an ACA Medicaid program. They don't have to do anything. It will happen automatically. Now, if there is a re-evaluation of their case, that's a wholly different issue. But their status in county care, it will just roll forward into ACA adult, for example, is one of the thoughts to have it. County care, the Cook County, the city, the state, and the federal government, I know, are currently in discussions about the medical consortium that provided the backbone, the care for the county care portion of it, what that means for them after January 1st. Moving forward, what will that look like? What will it be called? But those that were enrolled in county care are just going to roll forward into that program. They have nothing else they need to do.
We have a question there. Let me go back here with these two questions in the back. Why don't we start with Judy and then Murtis? Judy?
My name is Judy King. So I had two questions. The first one was if you could say something about the time frame for enrolling. Speaking of county care or Medicaid, for example, right now you don't go to a website and then at the end of your experience are enrolled. So anyway, I'm just wondering if you could say something about the time it will take for you to actually get enrolled.
For Medicaid specifically, or?
Whether, I would say both, because, because the online experience on the marketplace has been compared to, say, Travelocity or something like that. And then in that experience you have your reservation, so that's all. And then the second thing has to do with the discussion of access and quality. We heard the health department talk about breast cancer and the difficulty in getting mammography results. We did mention that the health department lost its grant to do that. It is a problem for women in Medicaid. Less than half of women in Medicaid are having their mammograms as recommended. My question is, what is the responsibility of CMS to monitor access to network advocacy and network quality in particular, since there are going to be many, many more choices for the new enrollees and the current enrollees in Medicaid and in managed care.
Great. Can you handle the second question first? Or do we handle the first question second?
Well, I can do both of them. And then Charles said I had to earn my money, so I wasn't talking enough. But let me cover the enrollment, and I'm glad you brought that up because I think one of the things that we've been stressing is, of course, is the fact that enrollment begins when? October 1st. And of course, we had other panelists who indicated that if you enroll by November 15 or December 15, then you're able to have coverage January 1st. Now, for this first year, it's a little bit different. We're actually having a 6-month enrollment period, and so that's what I just want to make clear. I don't think you can really stress that enough. Is that from October 1st until March 31st, people can enroll. That is our current open enrollment period. Okay. The difference, though, is that if you have to be enrolled by December 15th, December 15th, in order to get coverage January 1st. If you enroll, though, anytime after that, then your coverage will begin the first day of the month after that period, okay? So that's what we want to make sure about that. In terms of your experiences, in terms of the website, we did a lot of consumer research to make sure that it was very user-friendly and that we looked at things like Travelocity and Amazon and things like that to see exactly what kind of experiences their customers were having so that our consumers could have very similar experiences. We are also encouraging people to go through the website. We feel that if you go through the website, then it will be a lot quicker in terms of getting your information through and getting your coverage to be able to be started January 1st. But again, we do have other ways people can enroll. They can enroll, of course, on the phone with the 800 number we gave you, as well as with in-person assistance as well. So I just want to clarify that there are other options, and not just on the website. But again, that website should be driven where it's more. Yes.
I get my question about enrollment was really the time frame.
Okay.
Because what we're hearing from county care is that people are go and enroll, but it's been taking some people a couple months to
So you-
actually know that they are covered.
The actual amount
So
of
you
time for that
have-
to begin to be.
Okay, so you're actually talking about, like, for now, right now, that there might be a backlog, let's say, in terms of how people are getting. Do you want to take this? Dick?
Right. Well, there will continue to be the case management model with the expanded Medicaid, and there is a time lag from the time that the application is submitted, all the documentation is submitted, presuming that all happens concurrently, a lag time for evaluations of a case manager. The Medicaid rules in Illinois are that at the point that the application is submitted, that any bills for medical treatment can go back 3 months. And so while asking a person to be patient, to get on the Medicaid sometimes is challenging, the reality is that the system does make allowances for that. There is an online portal. I've been told that we don't need to talk a lot about that today, but the system is being digitized. And so it'll be much more streamlined, the application process for the expanded Medicaid and actually the traditional Medicaid program. I think that the consumer experience is going to be different. The other thing that I just wanted to mention, and this is one of those real things that I say, is that with the expanded Medicaid pool, there are going to be a lot different demographics that will be entering the Medicaid pool, some that have not traditionally needed or been enrolled in a Medicaid program. And I think for providers, healthcare providers, et cetera, there is going to be a different perception about the acceptance of a Medicaid patient, what that means, and the managed care model and those kinds of things. I think that there are going to be more providers that are going to be in the system that will look to accommodate the influx of patients. In addition to that, the federal government has been very wise to look at what is a health care provider. Can a nurse practitioner do some of the procedures that a physician could do under the general guidance of an MD? So there are many ways below the radar in which the system and the market, the healthcare market, not the marketplace, are being shifted. And these are just some of the ways.
My question is really to piggyback on what you just said about providers. There are a number of physicians that are really concerned about, as you mentioned, there's going to be an increased demand on search for providers. And we know there's only a finite amount of providers. And so with this increased demand, since so many more people are going to be eligible for health care insurance, and we know that just having insurance doesn't automatically assure access, to these providers. And you said some of the providers will take it because they may not have the stereotypical view of these Medicaid, expanded Medicaid beneficiaries. But what is anticipated about the number, the adequacy of providers, particularly physicians and primary care physicians? Because a lot of people fear that there may be an inadequate amount of providers to meet the demand.
Right. This is a complex issue, but one that the Affordable Care Act has looked to address straightforward. And while I work for the state of Illinois, I know that CMS and the other federal agencies take this very, very seriously, because there is a difference between insurance and access into the actual healthcare system. So the Affordable Care Act has done a number of things to address the supply side of it. And among those are loan forgiveness for health professionals that are going to be serving in urban and rural communities. There's some very specific funding streams for that. It is working with medical schools throughout the country to encourage and provide financial incentives for people to go, rather than into the specialties, to go into the basic family care, or the, I guess formerly they refer to as general practitioner. The changes in the definition of what the healthcare providers are and what they can do, nurse practitioner being one. The emergence of some of the pop-up clinics with the number, it's almost ubiquitous now, just to name a couple of names, Walgreens or CVS, the care centers that are there, and I think they're by and large staffed with nurse practitioners under the direction of an MD. So there are a variety of incentives, loan forgiveness, sponsorship of medical students, encouragement to change the supply. That's an important part of it. But the demand is going to rise faster than the supply. And so I can't preach to the choir, but I will say that the market, the health care market, is changing and shifting. There have been some very, very encouraging things out of some of the pilot programs that have been funded by the federal government via the ACA, Cleveland Clinic, the Mayo Clinic, the notion of having ACOs, medical homes, and looking to change the model in which the healthcare is provided, making it not based on the number of tests or procedures, but looking at it at incentivizing outcomes, engaging the healthcare professionals as a broad categories in the hospitals to do wellness and preventive care to help the patient stay better and get better, to have better outcomes, and that the compensation would be based more on that. And I think that's going to shift the need for the demand. The same number of patients, but the amount of care that it takes to get a person from this point to this point of health and wellness is shifting, I believe. And I'd be interested, maybe offline, hearing what your thoughts about some of this are.
Great questions that you had. First, getting to the idea about if people already have healthcare coverage and it's more expensive. This is really an opportunity for people to have more affordable healthcare coverage and access to healthcare coverage. A lot of people may have catastrophic plans or other plans that may not be beneficial to them, and so we would encourage them to enter into the marketplace for that particular purpose. In terms of, we actually had a question from a gentleman about children who live out of state, and I'm probably going to keep this over to Charles a little bit more, but essentially, again, when you go into the system, you are going to make sure that you have your income information and all of your personal information in terms of where you live and your children, your household information. And we haven't, Charles will talk more about this, but I believe that we've determined that a person can actually go into the website, put that information down, and then be able to select plans that will actually benefit their particular area. So we're getting clarity about that one, I'll be sure. But that was a very great question.
Thank you.
Yeah, actually superb questions. And again, the rubber hits the road when we make the determinations about what's going to be best for our health and our family's health and our finances. So if I were anticipating a college-age student moving out of state, that would inform some of the decisions I'd make about a health plan. A closed network health plan may not be the best choice for that. So that's what I have to say about that. In terms of engagement with young people, I've worked with several of the area universities, University of Chicago. We're going to be engaging with a number of other universities, and one of the supporter groups is called Young Invincibles, and it's young professionals that look to engage with young people on a variety of issues, and young 35 and under. young. So there are several things that I have to say about that. And one is that, and I explained to on a conference call with University of Chicago students the other evening. One is that many universities now make it a requirement that proof of insurance has to be shown in order to enroll and continue in school. And if you can't show proof of insurance, then you have to purchase a plan through the university. Oftentimes, it can be paid by your financial aid. So for the college students, it is important for them to know that 26 and under, they can stay on their parents' coverage. However, particularly in communities of color, those parents may not have jobs that have insurance. And so as we look at engagement, we need to engage it in a lot of different ways with young people in a lot of different strategies, and we plan to do that. The single biggest influencers of young people to do anything, actually, is the female models that are the strong female influences in their lives. The male influencers as well, but the reality, particularly in communities of color, there are a lot more of those female strong role models. So please, whether it's a son, daughter, grandson, niece, nephew, younger cousin, please encourage the young people to enroll and protect themselves, and not just protect themselves for their health and their finances, but the health and finances of their family. Because as we think about our families, we know that if there was an uninsured person in our family, a loved one, we would not allow them to go without a medical procedure. We would come together, and if we're a parent, we might mortgage a home to have this. Why get to that point? Protect themselves, protect their families. There's a reason why they're called young invincibles, because that's what they think of themselves. They don't think any harm will ever befall them. But the reality is something much different. So please encourage those young people to explore and get educated and enroll in health plans.
Thank you. And just one more thing, and that is the catastrophic plans. I was hoping maybe Rita could talk maybe about what that covers, but you're young and invincibles, because that comes up all the time, is that this is a plan that's cost a little bit less, and it has catastrophic coverage, and so that may be attractive too. You know, we're trying to encourage them to get the comprehensive coverage, but again, if that's an option, if they're like, oh, I'm young, I'm not gonna get hit by a bus, you know, all those kind of things like that, because you know how they are. I can say that because I was one of them 5 years ago. Yes. So, but that's also an option, but yeah.
Yeah, the catastrophic, it's only available for 30 and under, 30 years of age or under. It's a relatively low cost, high deductible. Again, the typical catastrophic type of coverage. It's an option.
Well, thank you once again. Let's give them another round of applause for their time. I want to underscore what Laura Leone kind of mentioned, that we're part of history. I mean, this is a historic undertaking. Not since Medicaid and Medicare have we had such a significant overhaul of our healthcare system. So I'm hoping that there were some takeaways from here, and we encourage each and every one of you in the next couple of days to visit our website. We will have a post-quarterly meeting portal where you will be able to access much of the information that was shared with you today.